Thank you for joining this new Tuesday Connect for May. So just a usual reminder and housekeeping rule. So keep in mind that this meeting will be recorded and shared on YouTube after the broadcast. So if you don't want to be recorded, just turn off your camera and post your question in the chat box. And well, please add your name and your institution when you want to speak. So yeah, we have information about yourself, and make sure to mute yourself when not speaking. And during the Q&A session, if you want to intervene, please raise your hand to facilitate the moderation. And well, you can either speak directly turning on your camera, or if you don't want to be seen on the screen, just write in the chat. And without further introduction, I would like to introduce Jeroen Schouten from our stakeholder forum. So after several sessions on JAMRAI, today we will talk about stakeholder work, and today Jeroen will talk a bit about Drive-AMS, which is a EU-funded project, but also about some ESCMID work. And well, main topic of his intervention will be implementation of antimicrobial stewardship program through Europe, how to build capacity and scale up. So Jeroen, the floor is yours.
Thank you very much. Thank you very much for having me today. I will try to share my screen. Yes, that should be working. So indeed, thank you very much. Thank you. My name is Jeroen Schouten. In background, I'm an intensivist. I work at the Radboud University Medical Center in Nijmegen in the Netherlands. And I'm quite much involved in the field of antimicrobial stewardship. And I was asked to talk a little bit about European capacity building programs for antimicrobial stewardship, and as they fit into the scope of the EU-JAMRAI project. And I will be talking about mainly the ESCMID AMS certificate course, which some of you will know, and I will talk about the Drive-AMS project. And they're quite aligned, but they're not the same. And they actually integrate with each other at different intersections. So I'd like to talk about those today. I know there's a lot of other activities happening, and we can discuss that maybe afterwards. I'll try to talk for about 35 minutes. And then I hope that we can get some good discussion on this really interesting topic of AMS capacity building programs. So we all know this, right? AMR is a global public health threat. AMS is one of the most important pillars to contain AMR, aside of IPC, aside of diagnostic capacity building, aside of access to antibiotics, etc. But AMS is very important. And also in the WHO people-centered approach, you will see that that should be indeed implemented in the national action plans. You'll see that one of the foundational steps of all those plans is to build capacity, to provide education, provide awareness, and to make people change behavior, whether it's doctors or it is patients. But it's very much also about capacity building. How do we build a good capacity of AMS stewards, of people who know about antibiotic use and who know how to curb inappropriate antibiotic use? So that's the start of this program. And what I usually do when I present is that I show the most important building blocks, in this case of mainly hospital-based antimicrobial stewardship programs, because the programs I'm discussing today are mainly about institutional programs. And I believe that there's actually three most important building blocks of hospital AMS programs. At the basis of the pyramid, as you can see it here, there are the so-called prerequisites. So the basics, the structural or systemic preconditions for which it's important that they're there to be able to start a stewardship program in a hospital. So what makes part of the structural and systemic preconditions? Well, first of all, availability of a trained group of stewardship members. So the availability of a stewardship team. So in the literature, there's a lot of support for that as sort of a basic principle, a basic requirement for a stewardship program. But it's not the only thing. It's also obviously you need financial support for the team. You need local antibiotic formularies, antibiotic guidelines, et cetera, et cetera. So there's a lot of preconditions that need to be met before you can actually really start with mounting a stewardship team. But it already refers to the capacity building. Another and the next step actually in the pyramid is to know what we want to, right? These are called the AMS objectives. We need to make sure that we are on one page related to what are the most important appropriate antibiotic use practices. We call that the what of antimicrobial stewardship. And it concerns things like, hey, when should you perform blood cultures? When should you treat a patient in what capacity with empirical therapy for how long? And when should you go from IV to oral switch, etc. So these are really practical, appropriate antibiotic use practices that should be executed in the hospitals and are often, as you know, not executed in the appropriate fashion. And finally, very importantly, there's a part that is often underrated and underserved in everything that we do in capacity building programs is how to actually change people's behavior in terms of that appropriate use practice. So how do we change behavior of surgeons to perform appropriate antimicrobial prophylaxis? And there's many different types of strategies or interventions that they're called AMS improvement strategies that can be used for that, such as audit and feedback, education, reminders, a lot of things, but you have to know to use the right intervention at the right time for the right public, for the right barriers, as you will understand. So all these aspects of antibiotic use are very relevant from the basis to the top. And this is very timely, this meeting, because this is something we've been working on a lot within ESCMID for the last years. And this is one very recent publication, actually came out last week, that describes the core competencies of antimicrobial stewardship teams, because all the members of those teams altogether have to provide the competencies that I mentioned in the three pyramids, right? They have to be able to create a stewardship team. They have to be able to know what is appropriate stewardship, and they also have to know how to influence people. So they have to know about behavioral change techniques, et cetera, et cetera. So in this paper, and I highly recommend it to you, it's now out in CMI, we've tried to develop in consensus the most important core competencies for stewardship teams in Europe. So it's a European project. And here you can see sort of an overview, and I won't go into that today. That's not the subject of the talk, but there are about 88 AMS competencies covering 15 domains to optimize an antimicrobial stewardship program. And you can see here, it's about governance, it's about infection management, it's about microbiology, diagnostics, pharmacology, up to quality management and behavioral change. So it's very broad. And as a matter of fact, and this is my link to the ESCMID AMS certificate program, as a matter of fact, all those different competencies are needed to know as an endpoint, if you want, for the capacity building program that we need in Europe. And indeed, before actually publishing this paper, we have been working on this for the last 5 years. The AMS certificate program is actually oriented exactly at those 15 different domains, covering in their courses all the different domains, all the different learning goals, if you want, for AMS stewards. Now, so let me talk about the ESCMID certificate program first. We started in 2022, and this is just a representation of the course that started in 2024 to give you the most updated program. We're starting a next course actually next month. So it's a 2-year training program that is oriented at ID physicians, microbiologists, clinical pharmacists, nurses, but also other specialists, but specifically at clinician or clinically oriented people who are part of stewardship teams or who want to be part of stewardship interventions in their hospital. So it's oriented at young physicians normally, or pharmacists, nurses, etc., ones that have just started a program. But it's open to all ages, of course, and also to all countries. It's a European program, and it covers, if you want, all the domains of stewardship in 10 compulsory courses. Right. So there's one 5-day sort of basic module And I'll get a bit more in depth in a minute. And then there's 6 advanced modules. They are compulsory as well, each lasting for 2 to 3 days. And then there's a choice of 3 elective modules out of a total of 9 extra available modules that will lead you a little bit more into detail in, more specific aspects of stewardship that you want to specialize in. That could be about pediatric, that could be about very, hardcore pharmacokinetics, et cetera, et cetera. But it could also, you could also choose to do 2 of those elective modules and then have a clinical observership in a recognized ESCMID center with a duration of about 2 weeks. So this is, if you want, it's the program. It overspans a timing of 2 years. And what is really interesting about this is that it's not only knowledge transfer, which you can see that's happening here, and observation. It's also invests in what we call the My Project. So all the participants have to perform a project in which they implement a stewardship intervention over a 2-year time period. And that's done partly, guided partly online by a group of experts. And I'll get into that in a minute. So this is, if you want, the overlook of the 2024-2026 program, starting with a basic course, as you can see, and then on the top layer, you see the mandatory courses over the course of time. So 1 basic course and 6 advanced courses over that time. And they cover all the relevant aspects that are also examined. So all these modules, they have an exam that people will have to make, right? They have to take the exam, they have to succeed at the exam. And then beneath there, you see the elective courses that people can use to top up their program. And then underneath there, you can see My Project. So they start at the basic course, they start choosing a subject for their project. And then the next steps, you will see, they will start measurement, right? Analysis of current performance, measuring the quantity and quality of antibiotic use. Then in the next step, they start prioritizing, analyzing facilitators and barriers, developing an improvement strategy, and they then execute that improvement strategy and finalizing by the end of the project by measuring again. So post-implementation, they have to learn how to evaluate again the quality and the quantity of use. And then underneath, you can see the different aspects that we add into the program and with progress webinars, and of course with support. And you can see that on the bottom, there's group mentoring, first of all, but there's also mentor support. Every participant, that we have 40 participants that start every year, every participant gets assigned a mentor who's an experienced AMS person, ID, micro, whatever, who helps this person to develop over the time that project and report on that project, right? The end of the story is that they have to write a report on this, and they have to submit that report, and it's rated on the different aspects that it should be rated on, and they have to write a good enough report to actually get the diploma, right? So this is in short what the AMS certificate program looks like. So the course participants mainly come from Europe, of course. It's a European program, but there's also participants from other countries, as you can see here. And I'll mention a bit later, but we're also starting a Latin American program. That's not relevant for the European setting, but we're starting a Latin American program starting from August this year. And you already see that there's a large interest from Portugal, Denmark, and from Italy and Romania. It's actually striking. These are countries where there's a lot of interest. We see that consistently. And that's important for you guys also to understand, because there are programs, there are countries where the programs where apparently there's more need for a capacity building program in MS than other countries in Europe. Now, does this work? So I'm just showing you some results of the evaluation of the first cohort of students that took place between 2022 and 2024. So we finalized the evaluation of the effect of this course on relevant outcomes, if you want, see if our teaching, if our education actually work, if the capacity work building really leads to something. And for the evaluation, we use the so-called Kirkpatrick model that has 4 different levels, and that obviously looks at satisfaction at the first level. How did they respond to training? Did they like it or not? We look at the level 2 on acquired knowledge. Did they actually acquire knowledge during this course? But we also look at attitude, behavior. Was the learning also applied? Did people change their attitude towards antimicrobial stewardship goals? And finally, did it actually lead to tangible, measurable results in practice, right? So really at the ground level of hospitals, performing a project like that, did that actually lead to improved patient outcomes or improved stewardship outcomes, I should say. So I'll go through this very quickly. It's not very interesting. This part is, don't think very interesting, but we evaluated level 1 and 2, the different types of course. Of course, there were people that were enthusiastic about the courses. There are also obviously some caveats and some negative points. On the right side, you can see the exam passing. So all the participants had to pass these exams. If they didn't pass, they had to take the exam again. So in the end, everybody sort of got to pass the exam. And so here, all the titles of the mandatory courses with the satisfaction grade and the past exams. And indeed, we try to increase and to change our program and ameliorate it every time that we speak to the tutors of these courses, the trainers of these courses. Interestingly, so it becomes more interesting when you look at the level 3 of the survey. So we survey people to understand where they are with their project, right? And I already sort of suggested that this project takes different steps. It takes different stages. People have to select their problem. Then they have to do a pre-intervention measurement using PPS or other types of measurement. Then they have to do an analysis of barriers. They have to do an implementation, so a real intervention. And then they have to evaluate that and write an abstract and a manuscript, right? So this is quite a big task, and we also evaluate that. But before I go into that, I want to make a sidestep here, because this is where actually Drive-AMS comes in. Because going back to this pyramid that I showed you, we think, and I think it's a philosophy of this program, but also very much of the Drive-AMS program, which I'll talk about later, that the core activities of performing stewardship are at the level interceding the what and the how. So it's really about measuring and improving. So what stewardship teams should do is measure and improve. It's one of the core definitions of hospital antimicrobial stewardship programs. And for that, Drive-AMS has developed a program. So if you want, Drive-AMS is inside. Well, you used to have this ads on, right? On Intel inside. You have this computer or your laptop and you have Intel inside. It's a core part of the program that's actually can be done separately, but it's also a part of the estimate certificate program. We call that Drive-AMS. And just getting back to what stewardship teams should do and what we should prepare our people to in hospitals is that they have to measure first. So they have to do some data tracking. They have to understand how to measure quantity of use data, quality of use data, how to interpret local resistance data. And pulling all that together, these AMS teams, they need to integrate the data, analyze the data, and then improve outcomes, right? They have to improve stewardship goals. And that they can do, I think, we feel, is in 2 different ways. So AMS teams in hospitals, they have a way of what we call rapid cycle improvement. And that happens mainly through daily monitoring and advice. This is what most teams do. When you have an AMS team in Europe, most teams actually do this. They have a direct intervention. They have direct feedback on antibiotic prescribing, right? And here, was a bit late with the cycles, but here you can see, so the rapid cycle improvement is something that really people do all the time. And here you can see how that works, right? Patients are selected based on clinical data or on microbiological data or on pharmacy data, and all that data comes together, whether it's done electronically or it's done on paper or however that happens, it comes together with the AMS team that then has to execute, right? It needs to perform actions. And it does that by, for example, feeding back on culture results, giving direct advice, or being present at a multidisciplinary meeting, or showing up at the bedside through consultation by an ID. And so this is a very important task of the stewardship team. But what we need to understand is that that's not enough. It's great to do that, but it's not enough because there's more going on. And looking at the data that you collect from the stewardship activities in your hospital, you have to also engage in what we call slow cycle improvement. And that slow cycle improvement is really to change perception or to change the perspective on the long term. So you can go to a ward every day and ask the hematologist to stop the meropenem. But you can also look at the group of prescribers as a whole, or at a specific clinical entity as a whole, and ask yourself, how can I change this as a whole? And that's a totally different perspective. That's not a rapid cycle improvement. That's a slow cycle improvement in which you need to really take on quality improvement methodology to make a change. And we strongly believe that AMS teams need to also do that, because it will help them in the long run. It will make them less, if you want, policemen of the hospital, and more contributing to sustainable change in hospital AMS programs. So for that, we jump into changing behavior, right? Into changing practice, and we make use of different models. But this is one of the models that is derived for Drive-AMS from experts in implementation science, and it's actually inside ESCMID AMS certificate training. So we ask our students to define the problem first, then to measure the performance, to analyze determinants, and then to develop an improvement strategy to address these identified determinants of practice. This is really the diagnostic part of the stewardship activity, and it sets it apart from the direct face-to-face interventions. It makes it more of a quality improvement project. So at the end, people make a project plan, measure after having executed an improvement strategy. So going back to the survey that we did, this is what you see happening over the 24 months of the ESCMID certificate program. You can see that all these different aspects are gradually coming together. So over the course of 24 months, people end up by having done their project. And this is, if you want, the level of completed projects. So within the 40 people that started the course, 35 of them completed the projects, all performed pre-measurements, most of all performed barrier analysis and interventions, and about 90% performed a post-intervention measurement as well. And that's important to recognize, because that means that they followed through with the project. And here are some examples of the type of projects that were performed, which were about prescribing empirical treatment, about improving perioperative antibiotic prophylaxis, about de-escalation and such, right? So they were all different. It was not the same project all the time. 65% of all participants to our ESCMID certificate program reached the level 4 of the Kirkpatrick model, which means that they had measurable impact. They showed in their project that they increased, for example, guideline adherence, or they showed that they could decrease in quantity metrics the broad spectrum antibiotic use over time. And they showed sometimes that they could improve also patient outcomes. Most of all, I think this program shows that most participants are trained to be effective antimicrobial stewards. And I think that's something that's underrated sometimes. It's really great to see that a group of 40 people over a course period of 2 years, where they see each other a lot, they communicate a lot, they create this AMS expert community, this European community that is not only valuable for their day-to-day practice, because I see them communicating every day through the app, to the WhatsApp group, but they are also tutors for future participants that are taking part in the course program. Because as I mentioned to you, the projects are not done alone. People are always helped by tutors, and those tutors are now increasingly the ones that have graduated from the course program. Now, if you're interested to see what those projects look like, you can look at the website of ESCMID, and you'll see these are freely available, the final project reports of the AMS certificate training. And we just added the cohort 2023-2025. So you see many, many different projects that have been done on many different subjects. Okay, so now, what are the future perspectives for this capacity building program? As I told you, we're getting a lot of ask from outside of Europe. So ESCMID decided to launch a Latin American program starting in August this year, in which all the live courses, so the on-site courses, are actually done in Latin America in different countries, but the online courses, and I didn't mention that explicitly, but a lot of those, especially the elective courses, are online. These courses can actually be taken together with the European group. And then finally, very importantly, because I know EU-JAMRAI doesn't only focus on hospital care, we are trying to develop an AMS certificate program focused more on primary care and long-term care facilities where there's a different need. And we are trying to do that together with UMO and with WONCA, so primary care organizations, to see whether a part of our projects, of our estimate certificate training courses can still be valid for primary care, and some of them have to be maybe adjusted or added. So that's about estimate AMS certificate programs. I want to finalize with a couple of words on the EU for Health Drive-AMS program, because Drive-AMS actually started as a EU for Health project. So it was a European grant that was started about 3 years ago. And it was really started as a synergy between measurement and improvement, and measurement being referenced by the global PPS, so by the University of Antwerp, and Drive-AMS, which was really the product of what we were doing in the university where I work for, in Radboud University. So these were the partners of that Europe-funded project with hospitals from Portugal, Lithuania, Greece, and Romania. And just as maybe as an open door, just to put the differences between Drive-AMS and the estimate certificate program in a table. The Drive-AMS program is really about the implementation part of stewardship, while the AMS certificate program is a 2-year full program that also focuses on very technical aspect of stewardship in terms of diagnostics, in terms of, as I told you, PK/PD, specific patient settings. So the Drive-AMS is really the part that is implementation science, that is implementation methodology applied in stewardship. So Drive-AMS has a strong link with global PPS as a measurement partner, while in the estimate certificate program, we use variable measurement partners over time. It's also an important difference is that the Drive-AMS program is mainly oriented at hospital teams. So we invite, in that course, we invite teams to come to the course program. So about 10 teams at the same time, while the estimate certificate program is really oriented at individual expertise in AMS stewards. So both do projects, but in the Drive-AMS program, we already invite the teams from the start. In the Drive-AMS program, we have an expert registry that I will touch upon in a minute that provides the coaching, while in the estimate certificate program, we have laureates from the previous courses who become tutors. So both we have a large cohort now of laureates that are tutors in the program. And of course, you can imagine that there's some crossover from one to the other program. So Drive-AMS is broader than Europe. We're mostly working in, we're also working in low middle income countries. I'm talking from Kenya right now, where we're doing a course this week. Estimate AMS certificate program is mainly oriented at Europe, but also tries to involve now other communities, especially in Latin America. Drive-AMS really covers the train-the-trainer principle. It's a real scale up. So we try to really build programs in countries where it's do one, see one, teach one, if you want. And that's not applicable in the estimate certificate program. That's really a firm, it's the same program every time. If you want, we repeat it every year for a 2-year full. Also, in terms of funding, it's different. Drive-AMS is funded by grants, by EU for Health, for example, but also by other grants like ICARS. And estimate AMS certificate program is a fee paid participant fee that makes the course go round. So this is the core Drive-AMS module. We invite teams. We ask them to prepare by performing a global PPS measurement, which we invest in together with the University of Antwerp. Then they come to a course program, which is a 4-day course program where they attend this sort of masterclass. They go through the same 5 steps as I showed you earlier. Then they go back home and they go and try and execute their project over a course period of 12 to 18 months. And they're then supported by an expert consultancy program that we've developed over time until they, perform their post-intervention measurement and write their report. So very much the same, but limited to the implementation aspects of stewardship. So this is what it looked like in the European context. We started with delivering a train-the-trainer course program. Then, this was a course in Nijmegen. Then we co-delivered to 4 different countries. Remember, Portugal, Greece, Lithuania, and Romania. So this was done last year. We performed what we call co-delivered courses, where we, as experts from Nijmegen and from Antwerp, helped out the different countries and did the course together with trainers from, in this case, Portugal. As you can see, different trainers, partly from Portugal, partly from Netherlands and Belgium. Same happened in Greece with participants from, obviously, with a lot of trainers from Greece, in Romania and in Lithuania. So there you can see that these co-courses really integrated the leadership of the program. And indeed, in the end, the next step and the last step that's happening right now is that these trainers who we trained during these two previous steps are now performing their own trainings. So every country now performs their own trainings without us being there. So this is the train-the-trainer principle. We're not involved anymore. They use the materials, of course, and we have feedback and we measure outcomes, but they are performing the course themselves. So at the end of 2025, we will have 30 trainers trained in implementation of stewardship programs. The course material is translated, of course. We'll have a lot of pre- and post-project global PPS measurement performed. There's a lot of antimicrobial stewardship trained. Of course, you can see here, this is the target, 330 antimicrobial stewardship trains. And we're also collecting here from different countries. Also, apart from these countries, we're collecting experts in the SPICE registry, which is also a part of the EU for Health program. So I'm not going to talk about this extensively. We don't have the time, but we're obviously also evaluating the impact of this Drive-AMS EU project. We do that in the same way. Remember the Kirkpatrick model. And what we know for now, but we're still very early in the evaluation, is that indeed we've been able to build 4 national training hubs for AMS education implementation. There's a lot of engagement and enthusiasm about the project. Of course, there's also the need for, and there's some challenges, especially on the complex topics on behavioral change, for example. We really need to involve more local behavioral scientists, psychologists. So I'm very happy that this is also an important part of the EU for Health, the EU-JAMRAI program. And of course, we don't know what the long-term impact is yet. We are still measuring now the outcomes based on indicators, but we still need to adapt the courses to local context, et cetera, et cetera. So there's a lot of things happening at the moment. It's still very much in flux, but it looks like the effects are going to be quite similar as the effects that I showed on the AMS certificate program that is organized by ESCMID. Now, if you're interested, this was shown at the poster at ESCMID Global. You can look it up. What is important, these are the project topics, as you can imagine, much the same as we've seen in the ESCMID program on duration, de-escalation, but also on microbiology, collection of samples, et cetera, et cetera. So it's really about improving quality of infectious disease care in those hospitals related to stewardship. What is really nice is to see that there's an impact beyond the hospital level implementation. So for example, in Portugal, parts of the program were selected as a part of the Sustainable Health Pact in Portugal. So it's really integrated in existing courses in Portugal, which I think is a really nice spin-off. We see that also in other countries, like in Romania, there's extra courses being provided. They're integrated in Lithuania. The course is increasingly integrated in the postgraduate training program for ID physicians, et cetera, et cetera, et cetera. There's a lot of research being done in the side, which is nice. And I think what we're seeing here, and this is where the link is also with EU-JAMRAI, of course, is that the Greek group that was trained by us in the first place actually performed the training program in Cyprus, which was part of the EU-JAMRAI project. So I think that's really, really interesting. In the meantime, together with our partners, we venture outside of Europe, East Africa, Indonesia, Caribbean, really using the same methodology. So the methodology seems to be working, and we really want to expand that beyond where we are working right now. So we're organizing train-the-trainer courses and webinar series to expand our group of trainers, if you want, because if we want to expand like this, we need more capacity also in the trainer side, not only in the stewardship, in the AMS stewards, but we also need to be able to keep on training those people. So this is our group. I'm going to stop there. If you're interested, this is a nice sort of a comprehensive guide to the philosophy that we have, and which you can review at your ease. So I'm going to stop here because I guess that we would like to have maybe some time for questions, and I'll give over back to you.
Thank you, Jeroen. So we have about 10 minutes for questions. So if you want to ask a question, please raise your hand or just intervene.
Maybe I can start. Thank you
Yes.
so very much, Jeroen. This is very clear and very interesting, and congratulations for all the work. I have two questions. One is what have been the main maybe difficulties to implement these actions in the different countries with the different infrastructure, organization, etc.?
Yeah, that's a very good question, and I think for that has mainly been interesting for the EU for Health, the Drive-AMS project. What we feel very strongly is that this has to be a roots up movement, right? It has to be a grassroots movement. If we are really oriented at professionals on the ground, the people who work with antibiotics every day, et cetera, et cetera. So when we tried to reach out for our first programs, we actually reached out to universities and to partners that we found in the countries that were interested in the field. We found them through our connections with Global PPS, but also through recommendations. So it really started from there. It was very much, let's see what we can do. And then we found that once you start adding on, then other hospitals would actually be interested to take part. And now that spreads, right? It's an oil flag that actually spreads. So I'm well aware that governments and MOHs should push down on, implementing stewardship, but you also need that grassroots movement, because otherwise, we're going to listen to MOHs. With all due respect, the clinicians are not going to listen to MOHs telling them what to do. It's not going to happen, right? You need professional societies, you need academics, and those are the ones that the professionals on the ground are going to listen to and are going to take their messages from. So I think that's a really important lesson for us, that we try to invest in relationships within the field of the clinicians and the people working on the ground. That was the part of the success. And you now see, for example, in Portugal, that it's going up the other way, right? So you see that the program is being integrated in national policies, and that's what we'd hoped would happen.
Yeah, definitely. Yes, thank you. And just another question in the context of this Tuesday Connect. I know that you have already started working with the EU-JAMRAI AMS work package, and thank you for that. So can you maybe for the entities resume where are the connections between EU-JAMRAI and Drive-AMS?
Yeah, so I think one of them I showed, and that is that I think we were able to provide actually some spillover from our EU for Health course program, and really in capacity building. In this case, it was in Cyprus. What we're doing at the same time, and I'm looking at it as a little bit broader. ESGAP has a connection, works, and I'm not representing ESGAP here. It must be clear, because I'm out of ESGAP now, but I've obviously been involved in the start of the project. We're helping to develop stewardship programs in the primary care setting. We're also helping in work package 6 if you want, in the development of implementation courses that are more applicable and broadly. And that's something we're still sort of touching base with the groups that are doing that in work package. I think it's work package 6, right? I'm not. Yes. And at the same time, working with Jose, for example, on modules on using AI in AMS, but also with and I just forgot the name of this lovely lady from Greece that leads that program, where we really work on using the information we have now to integrate them in the implementation programs throughout Europe. So we're trying to be a knowledge partner here, and because our project ends the end of the year, right? The EU for Health ends, so we hope to transfer the knowledge that we have by then to all of you, taking this a step further.
Thank you, Jeroen.
Any question in the audience? Don't be shy. Yes, Diamantis, please.
Yes, hi, Jeroen.
Hi, Diamantis,
Very nice to see you and hear about this really, incredible work you have been doing both with Drive-AMS and with ESCMID certificate. So you said that the project Drive-AMS is ending this year. So are there any plans for continuing this work? I mean, of course, there will be the capacity built already and the trainers, but is there anything else any other way that this could continue?
Yeah, thanks for that question, Diamantis. That's obviously what's in our minds the whole time, is how do we now take that next step? And I think we're doing that in different ways. First of all, we try to find additional funding. So we're looking at cost funding, for example, from the European Union, just to be able to add in other countries, right? And this seems like an efficient way. So we're trying to get some funding for that. I sincerely hope, and that's the hope I've already, expressed in Bilbao, but also now, is that we can somewhere integrate with the EU-JAMRAI program so it gets taken up further. And I'm not saying that we should take over the program, but it's something that I feel is in a momentum now, and it would be a shame to get it to lose it. So we're actively inviting hospitals to take part of this. We have a model in which this actually the program and the tools can be used, and we have this SPICE registry in which actually people can make use of the expertise. So it's free to roam if you want. But what I see happening is that in the countries where we are now, it expands well, right? So I think Portugal now has 70% of the hospitals have actually done this course, which is great, right? But it needs a little bit of extra. I mean, you need to have good leadership on the ground to be able to expand that. And especially when we go to other countries, and this is what we're trying to do with the COS program, maybe to connect, like we did with Greece. So Greece connects with Cyprus. So that's really clear. That was a really clear, but I would love to see, the Baltic states connecting with each other and expanding that program over the borders, which could be easily done because they're trained to do this. But there's indeed always some need of basic funding for this, and this is what we're still looking for. Thank you.
Okay, thank you.
We have time for one last question if you want.
I think I want to add one more thing, if I may, if there's no other questions, which I would be interested to know, because you are people from everywhere around Europe. And what we see happening in the ESCMID AMS certificate program is that we get a lot of applications every year, right? We get more than 250 or 300 applications every year for 40 places, and they come from the same places, right? So as I said, Italy is very interested in this course program. Denmark is. And we don't see anyone from France, for example, or we don't see anyone from Germany. Really interesting to see why that doesn't happen, because in ESCMID, there's obviously a lot of members, from Germany or from France. So I think that has to do with the fact that the national programs are already providing enough, or at least are integrating their stewardship training in microbiology trainings or in ID trainings. It's definitely true for the Netherlands, where we also don't have a lot of applicants, and that's because it's already there, right? So, and I think that's another, if you want, way out of this Drive-AMS, is that people take up the program, integrate it, like it happened in Lithuania now, integrate it in their training programs. That's also a way to make it more sustainable over time. But I'm very interested to know some comments of people say, well, I don't understand. Why don't people from my country don't subscribe to that course program?
I can just give you an answer from France, but I'm pretty sure you already know. But in France, there are already organized, I think, in many hospitals. I mean, the university hospital, there are what we call mobile teams for antibiotic therapy.
Yeah.
And if I take the example of my hospital, it's a 2,000-bed hospital, and the infectious disease specialists are called every day for the management of antibiotics. And now at regional level in France, there is I think at least 2 years, 2 to 5 years, I don't remember. There are organization and funding for the organization of regional center for antibiotic therapy to go from the hospital to primary care, and also try to also implement things in long-term care facility. I think long-term care facilities, it's tricky. And because also in France, we have 80% of the antibiotics that are prescribed outside the hospital. So clearly the target is primary care and long care facilities.
And I think, yeah, it should be. Yeah.
Yeah. So, but that's very interesting what you say. I think we need within the JAMRAI also to have this benchmarking. And I know that people from the AMS work package, and they are here, so I will give them the floor. But they have this survey to really know what are the needs and where, and maybe we have to concentrate then on the specific needs, and maybe a country like France, as I say, who is organized for having this sort of mentorship and organization of teams. Maybe it's not the country where we must implement, but
No,
we
I
are
agree.
in primary care, for example, and not in the hospital.
Yeah. Yeah, and just as a final note, I think what's really interesting to see in ESCMID certificate program is that sometimes we have people from, I mean, Czech Republic or Hungary or Romania now is hugely increasing, right? So the level of expertise of Romania in terms of stewardship has over the last 5 to 10 years really grown a lot. And you see that happening also because you really built the capacity at a top level, right? So we see all the people that were in the 2024 course, they are the leaders of the future programs. We need to have a program that really asks for excellence, right? So you need to have the top tier people, and we see those people. They are now, Dr. Graaf in Denmark. Our colleagues in Czech Republic, they are building the next generation, and we really need that and that's also roots up, grassroots up. We need that to build sustainable programs, and they're going to be the leaders of the future program. So I hope that works.
Yes, it will. I don't know if my colleagues from the AMS work package want to add something. I think Marta is there.
Blanca already left. I don't know. Maybe Pepe. Pepe is still online, but well.
I'll make sure to. I mean, you can share the presentation, of course, and so if there are any questions, I'm always happy to engage.
Yeah, thank you, Jeroen, and I think you have a lot of experience on the topic, and as you mentioned, we need to build up on that, and it's great that you are closely working with Work Package 6. So yeah, we will see where this collaboration brings us. Just to conclude this meeting, I have one last slide to share. It's not full screen, sorry. So yeah, just our next Tuesday Connect will be on August. The Tuesday Connect from June will be cancelled because a workshop is organized at the same time by the Commission on their feasibility study for One Health surveillance. So we don't want to collide with this very important meeting. And we really encourage you to join this workshop also on the feasibility study. So let's meet next time in August. So the slot is still open. We have already applicants for September, October, November, but August is still free. So if you want to apply for a Tuesday Connect, feel free to join us at our secretariat email address. Thank you again, Jeroen, and thank you all for joining. And well, we wish you a really pleasant day.
Thank you very much and have a good day.